So community health centers are the referral units for PHC. They are first referral unit for PHC and they function as secondary level facility in the rural health network. So the population norms, as we saw before also, that CHC covers approx 80,000 to 1,20,000 population in plains, and one CHC has 4 PHCs. Means one CHC receive referrals from 4 PHC, means 4 PHC, like one CHC के अंदर में like 4 PHCs comes, right? So objectives and expected functions, like again gynae and obstetrics facilities are provided, emergency operative care, public health programs are always a support. They support these public health programs. Diagnostic services are there. They support sub-centers and PHCs also in clinical, managerial and reporting functions, and they train the staff also. If we talk of staff, they have the specialists, they have the medical officers, dental surgeons, nursing staff, and various allied staff like lab technician, x-ray technician, physiotherapist, pharmacist. If all these facilities are present infrastructurally there at the CHC, so it's mandatory, means on the rolls or in the registers or on the papers they should have the inpatient capacity around 30 beds, OT, labor room, emergency department, then OPD, diagnostic services, pharmacy, medical records area should be there, infection control facilities should be there, biomedical waste should be managed, then other utilities, administrative utilities should be there, like for the laundry, for the kitchen, sanitation and all. Communication should be robust, and if possible the staff accommodation should be provided. So if we talk of these infrastructural facilities that has to be there, so we have a long list of equipments and supplies, like OT should have the OT table, anesthesia machine, surgical instruments, sterilization instruments. So we have a long list for this. So labor room should have this, diagnostics have microscope, analyzers, ECG machine, X-ray machine. These should be there. So we can have a what services are provided based on these, like we can see that outpatient consultations are provided, inpatient care has to be there, emergency services, basic general surgery can also be provided, newborn child health services are provided, family welfare services, diagnostic imaging services, public health functions, all are provided in a CSC. The main point is that health information records and reporting documentation should be there. NCD registry registers should be maintained, and routinely HMIS data should be submitted to the district and state authorities. So for quality assurance and standards, they should follow IPHS standards, Indian Public Health Standards, for infrastructure, staffing, equipment, and other services. Regularly visits, clinical audits should be there. CMEs should be there. If we talk of financing, they are funded by the central and state health budgets under NHM, and different schemes intersect with CHC services for institutional delivery. But still, there are common gaps and operational challenges because India is a very vast country. There is shortage of trained staff, infrastructure deficits are there, supply chain interruptions are there, weak emergency transport, and there is weak adherence to IPHS standards across the states. So if we talk of performance indicators, so for CHC functioning, we should have access to like bed occupancy rate, number of institutional deliveries done by CHC, what is the OPD attendance of patients, what is the referral rate, what does the HMIS data says. CHC's role in public health emergency. So it serves as a critical nodal area for outbreak detection and initial case management. So we have to go for isolation wherever feasible, and we have to coordinate with the district rapid response team so that the outbreak or the epidemic should not be there. So this is all about your CHC.